Hello, and welcome to Cracking Consciousness, the podcast where we crack open a mystery of the mind, one layer at a time. Delving into questions about neuroscience, technology, and mindfulness, we aim to simplify the brain and improve how you experience life and connect with others, featuring experts and community members to share their expertise and lived experiences. Today, I'm thrilled to be speaking with Dr. Alex Dalrymple, a movement disorders neurologist who specializes in treating patients with Parkinson's and Huntington's disease. Dr. Dalrymple grew up in Cary, North Carolina, and went to NC State University for undergrad, where he double majored in Spanish and biochemistry. He then went on to the Brody School of Medicine at East Carolina University, where he met his wife, Sarah, a family medicine physician, and then to the University of Virginia for neurology residency and an 18-month fellowship in movement disorders. He now is UVA faculty and is the director of the UVA Neurology residency program and the director of the UVA Huntington's disease clinic. He lives in Charlottesville with his wife, Sarah, and their two boys, Will and John, and their two dogs, Leo and Maggie. In his free time, he enjoys reading, traveling, watching football, and seeing live music. Dr. Dalrymple, thank you so much for joining us and being here today. I'm super excited to have this conversation and delve into understanding movement disorders, control, and emerging tech in the field.
Thanks so much for having me. I'm excited to have this conversation too.
I'd love to start with your story. You're at the intersection of clinical care, education, and research. What got you into the medical field, neurology, and specifically movement disorders?
Sure. So I was actually kind of a latecomer to medicine. Unlike my wife, who had known basically since she was 4 or 5 years old that she wanted to be a doctor, it wasn't until high school for me that I decided maybe this is the path I should take. In college, I majored in biochemistry, which I felt was actually really, really helpful in preparing me for medical school and helping me get through medical school. Then I went to medical school at the Brody School of Medicine at East Carolina University. Was really, really happy to go there. I think it's a great place. Again, I met my wife there, so I have to have a soft spot in my heart for it. I think as far as choosing neurology, most of my experience in medicine before medical school was in pediatrics. Both because I grew up as a child, but also because the pediatrician that I grew up going to see let me shadow him, gave me a job in his office, and so I had a lot of experience there. That said, I always kind of had a hunch that I would go into neurology, mostly because I felt like I wanted to specialize in something, right? I wanted to be the type of person who the buck stops with me, even if it's for one small thing. And then if I decided to specialize in something, it seems like the brain is the most interesting organ to specialize in. And that's obviously my bias, but I hold to it. But I wanted to make sure and keep an open mind through medical school, right? I had very limited experience with anything outside of pediatrics. I wanted to make sure that I wasn't pigeonholing myself. So I really did try to, not settle on neurology and see things as they came. The third year of medical school is when we do our clerkships. That's where we're actually in the hospital or in clinics, rotating with all these different specialties. And my clerkship year, I distinctly remember being on a lot of different rotations and thinking, well, I don't want to do that. And then another rotation, I don't want to do that. And then finally I got to my neurology rotation and I worked about 12 days straight inpatient in the hospital. And I remember, I distinctly remember this it was about day 11. I was taking a shower that morning, getting ready to go in, and I realized that I was actually excited to go in on day 11 in a row. And that's really what sold me and said, okay, I think this really is the career for me. So Sarah and I were soon to be engaged at that point. We knew that we were going to go to residency somewhere together, and we were very lucky that we both happened to match at University of Virginia. We had no intention of staying here. We came here in 2015, and we're both from North Carolina. But about a year or two into it, we both realized that we really like Charlottesville, we really like UVA, we really like our departments, the people that we work with, and so we shifted a little bit and decided maybe we could stay here. I also had no intention of staying in academics. Through medical school in the beginning of residency, I was pretty convinced that I was going to be a private practice physician, I was going to be a neurologist, I was going to see patients, that was going to be my job. I really had no desire to do more research or teaching or things like that, but I think about halfway through residency, I started to realize that some of my favorite days at work were days where I got to teach medical students or teach more junior residents or even teach patients. So I really, really enjoyed the teaching aspect of it. And I started to shift my mindset and think, well, maybe I could get a job in academics and just focus on teaching instead of research necessarily. During fellowship, though, I started doing some more research and realized that if you have the right research question and the tools and the skills and the system in place to back up your pursuit of that question, that research can actually be really fun. So now on faculty, I do tend to do all three aspects of academic medicine. So I see patients. I have a teaching role. I'm the residency program director for the neurology residency here, and I do some research as well. I try to focus my research on things that I think will help people. So Huntington's disease research, I'm trying to break into that world of potential disease-modifying. Parkinson's research, I'm working on a project to see if we can help people with Parkinson's disease walk better. And then I do a smattering of educational research too on things like how to improve the residency interview process.
Great. Thank you for sharing. It's funny how you mentioned that your journey to neurology was more of a process of elimination rather than I want to do that, and I know that since I was 5. I want to shift a little bit to understanding the brain in terms of movement disorders. As we know, to understand movement disorders, we need to understand movement. So can you walk us through what is movement, first of all, and then how is that different in movement disorders like Parkinson's and Huntington's disease?
Sure. So movement is complicated. Brains are pretty complicated, it turns out. But I'll try and simplify it in a way that is succinct while not skipping anything. Essentially, there are a number of different pathways by which our brain is connected to our spinal cord and in turn to our nerves and in turn to our muscles and skin and sensory organs. Some of those pathways are sensory in nature, right? So we detect something from the outer world, and that information gets transmitted up to our brains. Some of those pathways are motor in nature. Our brains direct our body to move in a certain way. The actual fundamental tract that leads to movement is what's called the corticospinal tract. That's where an area of the brain, the motor cortex, sends a signal. That signal travels down deep in the brain. It crosses over to the other side of the body in an area called the brainstem, runs down the spinal cord, goes out to a nerve that then tells your arm to contract. So if I want to lift my arm, that signal starts here on the right side of my brain, goes down into my left arm, and that muscle moves. If someone has a stroke, for example, where that part of the brain, that motor cortex, is injured, then they have a lot of difficulty moving that arm, right? They have a lot of weakness that develops in that arm. Movement disorders that I specialize in, things like Parkinson's disease and Huntington's disease, are a little bit different than that. So most movement disorders don't actually affect those corticospinal tracts. The corticospinal tract kind of functions as an all or nothing thing. If my brain says, I want this arm to move, then it says move. There are other pathways that help to control and modulate that movement, though, and can help me differentiate if I want to, try and curl a 50-pound dumbbell versus if I want to bring a very small cup of espresso directly up to my mouth, right? There's a different level of force that's required there. And so there are lots of other pathways that don't necessarily initiate movement but help to modulate it that are affected in most of the common movement disorders. So those pathways, things like the corticocerebellar tracts and spinocerebellar tracts, and then the indirect and direct pathways in the basal ganglia, are essentially constantly taking in sensory input and making small adjustments in the movements to allow you to have much finer motor control than just move or not move. In someone with Parkinson's disease, for example, I know everyone thinks of it as the tremor disease, but I'd encourage you not to think of it that way. Actually, the fundamental symptom of Parkinson's disease is something that we call bradykinesia, which means slower movement. Parkinson's is the quintessential hypokinetic movement disorder, where there's too little movement. So people have stiffness, they have a special slowness of movement, they often have kind of a shuffling gait, they may not blink as much, they may talk more quietly and more monotone. What you don't necessarily think about or decide during the movement of a body part is exactly how much force to apply, exactly where that's going to go. You just sort of know, for example, I can do it without even looking, that I want to move my hand directly to my mouth, right? And I can recalibrate the motion along the entire way, move my hand to my mouth. The ability of somebody with Parkinson's disease to recalibrate that is often impaired. The ability of them to initiate that voluntary movement is also impaired. So there's both the voluntary and involuntary component. Parkinson's disease is caused by a degeneration of certain cells that feed into those basal ganglia pathways. So there's less of a specific chemical in the brain, dopamine, which means there's less ability for the basal ganglia to control and modulate those movements, and the end result is that there's less movement overall. Now in Huntington's disease, which is kind of the quintessential hyperkinetic movement disorder, there's too much movement. These people are often squirming around in their chairs uncontrollably. There's degeneration of a different part of the brain, the caudate nucleus and the putamen, that then leads to an excess or overactivity of that dopamine pathway, which in turn leads to too much movement. So
I think movement, like walking or gesturing, is that part of how we experience being present and conscious in the world? And how would you describe, as diseases progress, how that movement starts to decline or maybe ceases?
yeah, that's a great question. I do think that being able to move, being able to respond to stimuli is a big part of being conscious and being alive. And in fact, I think, it was in undergrad at some point, one of my professors had mentioned that one of the fundamental definitions of life is the ability to detect and respond to a stimulus. So something happens and the organism can respond to that thing happening. In the world of bacteria, perhaps if there's a new antibiotic that's introduced near the bacteria, and so it can move away from that antibiotic and save itself. In humans, we have all sorts of different sensory inputs: sight, hearing, taste, smell, touch, and then our ability to move is our response to those stimuli. So I think even though we can be conscious while not moving, I think the ability to move and respond to stimuli is probably a fundamental aspect of us being alive and being conscious within our bodies.
Definitely. And beyond the physical symptoms of movement disorders, how would you describe the emotional toll that it takes on families and patients themselves?
Well, I mean, I can do my best having not lived it myself, but I've certainly seen a lot of people with it, and different people respond differently, of course, but it has to be really, really taxing, really tough for your body to no longer do what you want it to do. And that's one thing, if you're training to be an Olympic level gymnast or something and you can't do some crazy trick that Simone Biles can do and no one else can. But but whenever we're talking about fundamental, more basic tasks like walking or like putting your shirt on or like feeding yourself, if you know the steps involved, if you know how to do it, you just can't, that communication between your brain and your limbs is severed to the point where you struggle to do that. A lot of patients wind up getting pretty upset about that, and understandably so. I think the incidence of things like depression in patients with Parkinson's disease is really, really high, because how could it not be?
Sure. Shifting a little bit to treatments, there's lots of things that currently exist, and specifically I wanted to start with one that people may not immediately associate it with movement disorders, and that's Botox. Could you talk a little bit more about what that does, how it works, and why is it one of the go-to treatments?
Sure. Botox, first of all, technically is a brand name. Now, frequently we use the brand Botox, but we use other brands as well. Botulinum toxin is what we wind up injecting. As the name suggests, it's a toxin. It's derived from a bacteria, Clostridium botulinum. It's the bacteria that gives people botulism. Botulism is very, very bad for you. That's when the toxin gets everywhere in your body. But what some really intelligent people a few decades ago realized is we can take that toxin, we can purify it, we can inject it into specific places in the body and make it what it does help us. So it is the strongest, most potent neurotoxin that we know of in terms of weight-based dosing. What it does is it basically unplugs nerves from muscles. So the way that our muscles contract, again, is there's a signal sent from our brain, goes down into our spinal cord, where it sends that signal to another nerve that then goes to a muscle that contracts. Where that second nerve meets the muscle, there's what's called the neuromuscular junction. And nerves are kind of like electrical wires. So an electrical signal travels down the nerve. When it gets to that neuromuscular junction, that triggers the nerve to release a chemical called acetylcholine. That chemical then attaches to the muscle, and through a series of reactions causes the muscle to contract. What botulinum toxin does is it prevents the release of acetylcholine at that neuromuscular junction. So the nerves can still be sending a bunch of signals, but the signal doesn't get translated to the muscle. It is incredibly useful in a condition called dystonia. Dystonia is a different kind of movement disorder where people have abnormal extra movements that are often stereotyped, so it's sort of the same movement over and over. There's frequently a twisting component, but dystonia can happen in all sorts of different body parts. There's a lot of genetic causes of dystonia. There's a lot of idiopathic causes of dystonia. Basically, we don't know what happens. And dystonia can be everything from generalized, where essentially every muscle in the body is affected, to very focal, where only one or a handful of muscles are affected. Botulinum toxin injections are largely considered first-line and FDA-approved treatments for most kinds of focal dystonia. The most common kind of focal dystonia is something called torticollis, or cervical dystonia, where people may have abnormal contractions of neck muscles. So their head may be shifted or tilted. They may have a little bit of head shaking. We can figure out which muscles are involved, and we can inject botulinum toxin into those muscles. And within a few weeks, very often, those muscles start to relax and they're not contracting as much. So it's a cool treatment that we can offer to people that actually seems to really help their symptoms.
Definitely. And could you clarify, can dystonia and Parkinson's disease or Huntington's disease happen at the same time?
Yes, great point. So both Parkinson's disease and Huntington's disease can lead to dystonia. Dystonia only describes a type of movement, but there's also a family of conditions that are primarily dystonia, or it can be a part of other conditions like Huntington's or Parkinson's.
And how common is botulinum toxin used? Is it more recent? It was first used to treat dystonia in the 80s, but how common is it like across the world and across the US?
Across the world, actually, I don't know. That's a great question. I know one of the limitations here in the US is cost. It can be very, very expensive, sometimes reaching thousands of dollars a vial. Now, that said, it is almost always covered by insurance for the appropriate diagnosis, but that doesn't mean, that it's still not expensive. So I don't know about its use worldwide, and I imagine cost may be a big factor there. I know in the United States, a lot of movement disorder trained neurologists, those of us who focus on things like Parkinson's disease and dystonia, will perform botulinum toxin injections. There are a number of ophthalmologists who perform them for eye dystonia, eyelid dystonia. There's a number of physiatrists or physical medicine and rehabilitation physicians who perform botulinum toxin injections for not just dystonia, but for things like spasticity. If somebody has a muscle contracture after a stroke or after an attack of multiple sclerosis, those doctors can do botulinum toxin for those too. So it's a pretty widely used treatment for any kind of abnormal muscle contraction, especially if it's focal. The only reason that we don't use it as much for more generalized conditions, like generalized dystonia, is simply because the amount that we would have to inject would start to get dangerous, because a little bit of it leaches into the bloodstream with each injection, and we essentially run the risk of giving people botulism, which we don't want to do.
Yeah, definitely. And when you inject at small quantities, just because there's less in the body so it doesn't leak into the bloodstream?
Yeah, basically. So what we do is we evaluate the patient, we figure out as best we can which muscles we think are involved in the problem. For any given muscle, we have a rough idea of the range of effective doses of botulinum toxin. To use Botox as an example, for certain muscles, that range can be anywhere between 20 and 100 units. It comes in units. Obviously, that's a pretty big range, right? And for any given patient, it's very difficult for us to tell where in that range they're going to fall. So usually what I like to do is start somewhere on the low end of the effective range. Try that. It generally lasts for about 3 months. So when they come back 3 months later, we'll assess how it did and see if we need to up the dose or not. The way that we inject a lot of the botulinum toxin, there are different techniques, but a lot of people for certain muscles will use what's called an EMG machine, or electromyography machine, where the needle itself is an electrode and we can actually hear muscle activity. I find that to be really helpful in places like the back of the neck or in the arm or leg, where there are a lot of different muscles that overlap one another, because using that machine can basically tell me how deep I need to go with the needle. Once I start hearing the overactive muscle, that tells me that I'm in the right spot. As soon as it leaves the tip of the needle, I don't control it anymore, and it does spread out just a little bit, about the size of a quarter, maybe a ping pong ball. In some cases, like in cervical dystonia, when I inject the back of the neck, that's probably beneficial because, frankly, there are about 6 or 7 muscles back here that overlap and that all do pretty similar things. So if it hits some of those other muscles, that's probably not a bad thing too. In other cases, though, the spread of the toxin can be dangerous. So in some cases, we inject the front of the neck, and in those cases, it could spread and it could hit swallowing muscles, for example. And we don't want to unplug nerves from swallowing muscles. We want those to keep working. In some cases, we inject in the ribs or in the side here, and it could spread and hit the diaphragm or your main breathing muscle, which obviously would be very bad for you. And with each injection, there's probably a little bit of the toxin that does make its way through the capillary system into the bloodstream. But by limiting the total amount of toxin that we inject in any given person, we think what we're doing is we're limiting the systemic effects of the toxin elsewhere.
So from deep brain stimulation to botulinum toxin, and I've even seen new wearable sensors track tremors, there's a lot of new technology. Are there any advancements that you're particularly excited for, that you have your eye on, or even things that don't exist but you're trying to make something happen yourself?
Yeah, that's a great question. I think there are two big things in the two main diseases that I see and that I treat: Parkinson's disease and Huntington's disease. So for Parkinson's disease, I think it's a complex issue. I think one of the main problems in Parkinson's disease research is that we're still not entirely sure what exactly is causing the damage in the brains of people with Parkinson's disease. We're pretty sure that it has to do with an abnormal protein called alpha-synuclein, but why that protein behaves abnormally, why it forms these clumps within brain cells, why those cells then selectively die off, we're not really sure. My suspicion, and I don't think I'm alone in this, is that there's actually a bunch of different underlying causes that then all have a common pathway. And that those different underlying causes probably help to explain why one person's Parkinson's looks different than another person's. So the best analogy I can come up with, and I've used this for some of my patients too, is cancer. So 100 years ago, someone got cancer and died of cancer. And then at some point, the medical community realized that lung cancer behaves differently than colon cancer, and different than breast cancer, and different than skin cancer. And so we started classifying different cancers based on where they start in the body and what kind of cells they originally were before they mutated into cancer. Nowadays, patients aren't even diagnosed with, breast cancer anymore. It's a very specific kind of cancer in this very specific spot. They use all sorts of molecular techniques to say, the cancer has these mutations, it has these receptors, it doesn't have these receptors. And essentially, the more that the oncologist can drill down into exactly what the problem is, the more they can give the patient a tailored treatment to that specific problem, right? So the mythical, quote, cure for cancer is probably not going to happen. What's going to happen is we're going to develop, and already have developed in many cases, specific cures for very, very specific kinds of cancer. I think that's where Parkinson's is headed. I think we need to figure out, for Mr. Smith over here, what type of Parkinson's does he have? What is his underlying cause of Parkinson's? Once we know that, then we can better design and tailor treatments to fix that specific thing. I think one of the reasons that the oncologists have a head start on us in this realm is think about studying it, right? Cancer doc has the advantage of being able to take a tumor, cut it out, and look at it under a microscope and do all sorts of stuff with it, whereas most of my patients prefer that we keep their brains inside their skulls for now. So it's a lot more difficult to study a living human brain than it is a tumor, I think. But there are a lot of people who are a lot smarter than I am, who are getting lots of research money to look into this exact question and try and figure out, why does one person or one group of people develop Parkinson's and another group not? What makes one person's Parkinson's different from another? And I think once we better have that defined, then we can really start figuring out ways to slow down or even stop progression of disease in these specific subtypes of Parkinson's disease. So Huntington's disease, unlike Parkinson's disease, is actually slightly better understood because Huntington's disease is a genetic condition. It is a single gene mutation. So within one of the genes in chromosome 4, there are too many what are called CAG repeats. What that leads to is the protein that's created by that gene having too many glutamines in a row, and that makes the protein fold abnormally, which means that it doesn't work the way it's supposed to. Now, I was purposely vague there because, admittedly, we're not entirely sure what the normal protein is supposed to do. We have a lot of hunches. We know that it's a very big protein. We know that it's used in a lot of places all over the body. But one of the places that it is most widely expressed is in these cells deep in the brain, in a place called the striatum, so the caudate and the putamen. Those are also the cells in the brain that degenerate the most in patients with Huntington's disease. So because it's a single gene problem, there are actually multiple trials going on right now or about to start right now in humans looking at different ways that we can reduce the activity of this abnormal gene. Some of them are pretty brilliant. The way that a protein is created is there's the DNA double helix that has sort of the master copy, master blueprint of all proteins in our cells. That DNA is then transcribed into RNA, which is sort of like a copy of the blueprint. And the RNA is translated into the protein, so that's like taking the blueprint to the actual job site and then constructing a building. There are these things called antisense RNA oligonucleotides. What they do is it's sort of like intercepting the person with the copy of the blueprint before they get to the construction site and having them shred the copy of the blueprint. So it never gets to the construction site, so the protein is never actually built. Now, some of these treatments have a hard time differentiating between the mutated protein and the normal protein, so they just knock it all down. Some of them can be a little bit more selective, and like I said, they're in trials or are about to start their further phase trials in humans to see if this can actually slow down progression or even stop progression of Huntington's disease. There are other ways that people are looking into it as well. So there are, instead of just reducing the protein, there are ways that people are trying to reduce the downstream effects of the protein. But regardless, I think the Huntington's world is pretty excited because it really seems like at some point in the relatively near future, we're going to have, I hesitate to say the word cure, but we're going to have a true disease-modifying treatment for this disease, something that can really, like I said, slow down or even stop the progression. So that's really exciting.
Yeah, definitely something to look forward to. And kind of relating to that, is genetic testing a thing within movement disorders, and how is the research on that looking?
Yes, so there's quite a bit of genetic testing in movement disorders. Going back to Parkinson's disease, somewhere between 5 and 15%, we think, of patients with Parkinson's disease have a genetic cause. Obviously, that's a pretty broad range, but not every person with Parkinson's gets genetic testing. So I probably have a number of patients who have genetic causes that I just don't know about. The reason people don't get testing yet is because it doesn't necessarily change how we treat them. Again, as research advances and we delve more into the underlying mechanisms of what leads to Parkinson's disease, I bet there will be more and more people getting tested because I bet there will be treatment implications. But for right now, it doesn't necessarily change things, so I don't necessarily offer testing to people. That said, most people with Parkinson's disease are the only person in their family with Parkinson's disease. If someone has a first-degree relative who's been diagnosed with Parkinson's disease, so a parent, a full sibling, or a child, then that person probably has about double the risk of developing Parkinson's disease compared to the general population, which sounds bad until you think about what the actual numbers are. The general population has about a 1% risk, so a person with a first-degree relative probably has about a 2% risk. It's double, but it's still fairly low. Now, for Huntington's disease, again, it's a single gene disorder. It's autosomal dominant, which means that all you need one copy of the mutant gene inherited from either of your parents. And if you have 40 or more of those CAG repeats, you will develop the disease at some point in your life. Patients with family histories of Huntington's disease or who are developing symptoms of Huntington's disease can often get genetic testing to determine, is this what's going on in myself? Now, the genetic testing in Huntington's disease is a very interesting topic because symptoms of that disease often don't show up until people are in their 30s, 40s, 50s, or even later in life. Which means that somebody can have the gene mutation, have the susceptibility to the disease for decades before they start actually having symptoms. Right now, we don't have a disease-modifying treatment for it, and it is a progressive degenerative disease, so before we test people who are asymptomatic, we really have long discussions with them to make sure that they understand what the results might mean. We want to make sure that they're not going to make rash decisions if they get a result they don't want. And so that process is really fraught with a lot of delicate conversations, shall we say. And then finally, there are a lot of other movement disorders. So two big families, I already kind of mentioned the dystonia disorders. There's a whole range of genetic conditions that are abbreviated DYT, T1 through, I don't even know what we're up to now, 45, 47, something like that, that are essentially a bunch of different genetic mutations that lead to various dystonia syndromes. A handful of them have specific treatment implications, so I do send testing for those quite frequently. One of them, DYT11, is a mutation in the epsilon sarcoglycan gene and has very good evidence that a medication called zonisamide can help to reduce some of the symptoms. Likewise, there's a family of conditions called the spinocerebellar ataxias, or SCAs, that lead to ataxia, which is another movement disorder. It's basically a problem with the cerebellum, the back part of the brain that helps control balance and coordination. And these disorders often run in families. We can test for them, and like the DYT disorders, a handful of them have pretty specific treatment implications as well. So a relatively newly discovered spinocerebellar ataxia mutation, it's spinocerebellar ataxia type 27B, has a specific treatment that there's pretty good evidence that helps reduce the symptoms. That treatment is called dalfampridine. So both the dystonia genetic testing and spinocerebellar ataxia genetic testing, those syndromes are relatively rare, so I don't send off the testing that frequently, but generally if I see a patient who has those symptoms, I will almost always send off the testing.
Yeah, it's so good to learn like how much genetic testing has evolved over time, and like how hopefully in 10 years time it'll be more useful once the results come back. There's more treatments that can actually be done.
Yeah, definitely. I think we're learning more and more about genetics essentially every day, and the tests are becoming more accessible too. So I know when I was early on in residency, not even 10 years ago, right, genetic testing was often prohibitively expensive for a lot of people. It'd be thousands and thousands of dollars. Nowadays, not that far in the future, it's much, much more affordable. There are still some companies and some tests that are very expensive, but for the most part, a lot of my patients now may pay a few $100s out of pocket, if that. A lot of companies are essentially charging $0 out of pocket because it's become more and more utilized.
Yeah, that's great. I want to end on a more personal side. You've worked with many patients and their families, often over long periods of time. What would you say one experience or a couple that stand out in particular with patients where you've really learned more about yourself or about the people you help?
Yeah, that's great, and it's hard to pick even just one or two. There have been a lot of patients who've stuck in my mind. I mean, off the top of my head, there's one in particular who recently passed away. He passed away in April from Huntington's disease, shortly after turning 18. So over the years, I had gotten to know him and his family pretty well. They're a great family. They're very supportive, and it was really special to get to see them every now and then like I did. But it's still hard to see somebody who just turned 18 pass away. Pivoting from patient stories, two things that certain mentors have told me that I really try to keep in the back of my mind. One was an attending physician, one of our neurologists here, who, when I was a resident, I was in clinic with her. And residency can be very difficult, right? You work long hours, you see a lot of patients, you're very stressed out often. And so I had a particularly challenging patient who was very nice but had brought stacks of old records and was convinced that I was going to be the person to finally figure out what was wrong with him. And I had to do all of this, read his hundreds of pages of records and see him and examine him and talk to my attending physician about him, all in like 45 minutes. There was no way I was going to be able to do that. So I came out and I started talking to this mentor of mine. And she was like, whoa, I'm going to stop you right there. I can tell that you're pretty overwhelmed right now. Don't worry about all that stuff. Anytime someone comes to see you as a doctor, the fundamental thing that you should be thinking is, what can I do to help this person today? Sometimes that's talking to them, examining them, making a diagnosis, starting a treatment plan. Sometimes that's just listening, right? Sometimes that's just being there for people. Kind of dovetails into another piece of advice that I got from a different mentor, who, her catchphrase says, there's never nothing more we can do. There may not be new medicines, right? But we can always be here, we can always listen, we can always, through our experience and again, simply by being there for patients, we can make sure that whatever it is they're going through, they're not going through it alone. So in a field where we frankly don't, as of right now, have that many treatments that stop these diseases or reverse these diseases, I think trying to keep that in the back of my mind is what helps me process it, helps me be present for my patients, and hopefully helps me continue to strive to be a better doctor.
Yeah, thank you for sharing that. For the average listener who's learning more about movement disorders, how can they better support those around them?
Yeah, that's a great question. So a lot of my patients tell me that they often feel embarrassed by their movement disorder. They feel like people are judging them or watching them or treating them differently. And so I'd really encourage folks to, especially if it's a close friend or a loved one who has a movement disorder like this, acknowledge it, but then try not to let it color how you treat that person or how you feel about them. Try not to have secondhand embarrassment or try not to make a big deal if, for example, they have a little bit of shaking as they're moving their cup up to their mouth.
Definitely. I think the idea of feeling comfortable in a space is so important, and that really just highlights the importance of being able to be with people and not feeling judged for how you are. And do you have any advice for the family of someone dealing with a movement disorder?
Yeah, I mean, I think there's talk about it with people. It can be difficult, but try to maintain your relationship as a family member too, not just as a caregiver. Lots of different people have lots of different strategies for doing that, but I think the most successful families I've seen have been the ones who are able to sort of have boundaries and understand that there are certain things that a family member should do or could do for their loved one, and there are certain things that maybe someone else needs to be the caregiver so that the spouse or the child can be the spouse or the child. I think even if we don't necessarily have ways to modify these diseases quite yet, we have a whole lot of treatments that can ideally help improve quality of life, and really that's my main goal whenever I'm seeing a patient, is to try and maintain or improve their quality of life for as long as possible.
Dr. Dalrymple, thank you so much for sharing your time today. It was an absolute pleasure learning more. And I think the work that you do, helping people live their life however they would like to during their journey, is so meaningful. So thank you so much.
Thank you.
And to our listeners, thank you for tuning in, and come back next week to hear more deep dives into the brain, body, and beyond.